Hello, everyone. Welcome, and thank you for joining the 31st webinar in our Pandemics and Society series. Today's topic is measles, why it's back and what it means. I'll now pass it to our moderator, Jennifer Nuzzo, Director of the Pandemic Center at Brown University's School of Public Health. Jennifer?
Thanks so much. Hello, everyone, and welcome to our discussion. Measles was declared eliminated from the United States in the year 2000, but in the last year, it's back with a vengeance. There have been more than 2,600 cases since an outbreak began in January 2025. It's the most cases since 1991. This outbreak has actually been the deadliest on record since elimination 25 years ago. The outbreak is showing no signs of slowing. In fact, case numbers have been increasing in recent weeks, with more than 200 cases per week in the last month. Really a stunning development. And as a result of all of this local transmission that has lasted now for more than a year, the United States status as a country that has eliminated measles is in serious jeopardy. The Pan American Health Organization, PAHO, which regularly reviews data and classifies disease statuses for countries in the Americas, will next meet in April when it's expected to review whether the United States will keep or lose our measles elimination status. And though our conversation today will focus on the United States and our experience with measles, it's important to note the United States is not the only country currently struggling to contain the disease. This week, the World Health Organization announced that 6 countries in Europe have lost their measles elimination status. We know in November, Canada lost its measles elimination status. So we know that acknowledge that measles is a global problem, but we are going to focus today on the outbreaks that are occurring in the US. We know that the MMR vaccine is our best defense against hospitalization, death, and long-term consequences from measles infection. There are decades of evidence to support the safety and efficacy of vaccines. And yet, what we have seen in terms of the communication in response to this measles outbreak has really been muddy about the role of vaccines. And in the eyes of many, may have serve to sow distrust or to reduce uptake of this life-saving tool. There are many communities that we're worried about, and in looking at the data that show low vaccine uptake, certainly well below what we would need to prevent measles outbreaks from occurring. And so there is concern that this muddied communication could reduce protection in communities throughout the United States even further. At the same time, we're hearing kind of mixed reactions from health officials in terms of, how seriously to take this, and also whether measles elimination, the loss of that status, would be problematic. I think just last week, the principal deputy director of the Centers for Disease Control and Prevention said that were the U.S. to lose its measles elimination status, that would just be the cost of doing business in a globalized world. So we need to talk about this. What does it mean that the United States is going through this experience? What would a potential loss of measles elimination status? What are our biggest worries for public health right now in terms of dealing with the outbreaks, but also long-term effects? So that's what we're going to talk about today. And I'm very pleased to be joined by 2 key experts in the field. First off, we have Lori Handy, who is the Associate Director of the Vaccine Education Center and Associate Professor of Clinical Pediatrics within the Division of Infectious Diseases at the Children's Hospital of Philadelphia. I'm also happy to include in this conversation Liam Hicks, who is the Manager of the Vaccine Preventable Disease and Respiratory Disease Programs at the Arizona Department of Health Services. Thank you both for joining today. And with that, let's dive in. And just to say to folks who are watching us and who are tuning into this webinar, we will have a question and answer portion, which we will get to later. Please, at any point, feel free to put your questions in the box, but I will take the moderator's prerogative and start the conversation off and pose some questions to our panelists here. So I raised this question about measles elimination and sort of what does it mean? And, perhaps there's been some conflicting dialogue as of late as to whether the U.S. losing its measles elimination status would have consequences or mean anything. Maybe pose the question to both of you. What are your thoughts on this potential? Now that we're at the year mark, what's the likelihood that you think that we would lose our measles elimination status, and is that a problem? Maybe Laura, I could start with you and then turn to you, Liam, if you have thoughts to add.
Sure, sure. Yeah, I think when there's the comment of d does it mean anything?
Mhm.
What I think it means is actually something even bigger than measles, which is, measles is really the canary in the coal mine, right? That first flag that there's something very wrong, because it's highly contagious and spreads so easily. So it's going to be our first signal that we are seeing essentially breakdown of our immunization programs and probably cracked under that, our ability for public health and for healthcare in general to bring really basic preventative services to people. Now, is that because we don't have the right access or the right resources, or is that because our country doesn't necessarily trust those resources, or want to use them, or because the information is wrong or muddy or confusing? All of those, right? And so, it's not just about measles elimination, and the fix is not just let's just make everybody understand MMR is valuable. It's, get at these root causes of public health infrastructure and pediatric care and communication and all of the things that came together to get us to this moment. So, it's a very big deal in that way. And that's why, I think we should take that as it's not just about a measles outbreak, it's about what's underneath that.
Yeah, and I mean, for people who maybe haven't been paying attention to measles before all of the headlines, just to say that in the past 20 years, the definition of elimination is that we don't typically have domestic transmission of the disease. Maybe the majority of cases are usually from people who have traveled abroad, and then there may be some transmission to people they've been exposed, but we've usually been able to contain them quite swiftly. The
Mhm.
situation we're in now, where this outbreak has gone for longer than a year, is somewhat rare in terms of what we've seen historically. So we are in a different situation. Liam, let me turn to you. I'm wondering if from the local perspective, that this new phase that we're in, or the larger questions of elimination, or just the return of measles to the United States, what that means for health of our communities.
Sure. Just like I guess, paint a picture of what that elimination status means in the local community. So what it means is that disease is spreading locally again. People are catching it within the community and not just from international travel or travel. That means our schools, workplaces, families, and events can all become points of transmission. It means higher risk for the vulnerable people, so the infants, elderly people, and pregnant people, and those with weakened immune systems face greater dangers, even if most cases may be mild for others. It means that you may see more outbreaks and disruptions, as we've seen over the last year. You may see school or daycare exclusions, event cancellations, more sick days, and hospital visits and public health alerts. It means more pressure on the local healthcare system and public health agencies that oversee some of those geographic locations. Clinics and hospitals may see more patients, longer waits, and staff burnouts. It means public health measures ramp up. The community might experience more vaccination campaigns, public alerts, exposure notices, and more interactions with public health as contact tracing and monitoring continue. Effectively, big picture for a community, losing measles status means measles has gone from almost unheard of to a real present risk again. It's a warning sign that community immunity has slipped and that protecting each other matters.
Thank you for that. It's really stunning. Measles elimination as a goal was defined, say in the mid 90s. And in the year 2000, the United States demonstrated that it achieved those goals. It was a decision made based on the assessment of how bad it was to have measles, as well as what tools we have to combat it, and the cost effectiveness of using those tools to drive to near zero local transmission of measles. Um, we set those goals a long time ago. We've all, as a global community, thought that these were worthy, important, and beneficial goals. We achieved it. We are clearly in a very different state now, both in the United States, but also globally. And I guess the question is, how did we get here? How did we go backwards so profoundly? By usually in health, you don't usually see a backsliding of decades worth of progress, except under really extreme conditions. So I'd love your thoughts on how we got here and what does it mean? And whoever wants to start
Yeah,
then.
I can start,
Sure.
and again, there's so many ways we can go with this question, but the first piece that I think has been really pronounced in honestly the past year is the amount of individuals who believe measles is actually just not that bad, right? And so when you look at the efforts in the 80s and 90s to eliminate measles, or you look in the 50s and 60s to drive down polio, that work is done by people who saw that, who saw the pain, the miserable children, the hospitalizations, the death. And so this is not something we think children should experience. Um, and now the people who have that voice of this is not something a child should ever experience are so small because so few people see these diseases. So, when the risk of disease is very, very low, and at the same time, there is a, say, perceived risk of vaccine, the preventative measure, because of all of the online rumors and the confusion. You now have people who are doing a risk calculation for themselves so that, it is actually, mathematically wrong, but to themselves feels right to say measles is not a real thing I'm worried about in my day-to-day life. Maybe I'm worried about a car accident, or maybe I'm worried about flying on an airplane, but the measles, like, I've never seen it, never heard of it. My friends have never seen it. That's just not a real thing. Plus, I've heard all of these other pieces of information about the vaccine. And at the same time, the ability, again, of like our public health systems and our healthcare professionals to respond to those questions or rumors or misinformation is very limited, just because we don't have necessarily the time or the humans to have all of those needed one-on-one conversations. So I think measles is a little victim of its own success, right? In that the fewer people that know about measles, the less scary it is. Plus, this overwhelming change in our information atmosphere of people just receiving different information than what maybe their general pediatrician wants them to have, and then having no way to undo that because of limited resources.
Can I ask you to wear your clinical hat for a moment and just tell us what measles really is? I mean, what does the evidence say about measles disease for people who haven't seen it? They think it's this quaint thing that maybe their parents or their grandparents got, but they survive. So what's the big deal? Can you just talk a bit about the tolls of measles?
Yeah, yeah. So measles, I mean, I have two kids. It's something I would never wish a child to experience. So, it starts looking like a common cold, 2 days of runny nose, cough. You think it's not that big of a deal. But very high fever comes with it, 103, 104. And then usually by day 3 or 4, people get that kind of classic rash. And what comes with all of that, the high fever and the virus just kind of moving through a child's body, usually this is children we're talking about, you're getting dehydration, vomiting, diarrhea. The virus can move into the lungs, and so kids will have difficulty breathing. They'll need oxygen. They'll get viral ear infections. And what this means is that leads to hospitalization rates somewhere in the 10 to 20% range of children needing to come in because they can't stay hydrated or they can't breathe. And that's the common bad stuff. On top of that, you then have maybe 1 to 3 out of 1,000 who might have swelling of the brain or who would die. Now, you think of other infections that kids have, the common cold or like a bacterial ear infection. Very few people know of a viral infection or bacterial infection where the rate of death is 1 out of 1,000. I mean, that's very, very high. And so when vaccines were created, and for all things that we have vaccines, we have created them because these are things that we don't want children to experience. The last case of measles that I saw was admitted in our Philadelphia hospital. The general pediatrician who was with me looked at this baby who was just frankly miserable. I mean, there's no other word. And the pediatrician said, I just didn't know she would be this sick. And I said, I know that's the problem, is that even, very well-trained pediatricians said, like, I couldn't really wrap my mind around it. And you can't until you see it. which is why we are, parents saying, what's a couple days of fever? I mean, it's not good.
And it's also, I think, important for people to realize that we also worry that there's long-term health consequences for people who survive their infection. There was this tragic case recently in Los Angeles where a child died after having gotten measles as an infant, too young to be vaccinated, and then experienced a rare complication that resulted in death years later, which is something we also worry about. We also worry about long-term effects on the immune system and potential neurologic effects. So terrible disease. I also am a mother of two kids, and like an ear infection when you have a baby is a miserable experience to go through. These poor children are suffering, but to think of how sick kids could really get from this disease, I mean, it's just I don't wish that for any parent. Liam, can I turn to you maybe and talk a bit about, Arizona has experienced an outbreak and sort of in this on this topic of where are we today and what have we been seeing and what has the impacts been? I wonder if you can offer some local experiences in terms of your communities.
Sure. So, what we're experiencing in Arizona is very similar to measles outbreaks around the country, especially in this new vaccine preventable disease landscape that we are trying to navigate post-pandemic and in the last 10 years, frankly. The biggest factor is low vaccination coverage. As we've kind of reviewed, measles needs about 95% vaccination coverage to stop spread when the virus is introduced into a community. If coverage drops even a small gap, it creates a big opening for the virus to be transmitted and grab a foothold. Clusters of unvaccinated people, even in otherwise well-vaccinated regions, are enough to fuel an outbreak. So you just need to find that one cluster of unvaccinated individuals. I think the biggest part of how we're navigating the new vaccine preventable disease landscape is social dynamics. They play quite a big role. Tight social networks often amplify spread, as events and gatherings may lead to some large exposures and transmission. There's many challenges in controlling the spread of measles. Once measles gets a hand in the pocket of some of these low vaccination coverage areas, it may be difficult to control once it starts spreading. As we know, measles is one of the most contagious diseases known. It's airborne. It can linger in the air for up to 2 hours after a person's passed through that airspace and has a high attack rate. The common stat that we see is that 9 out of 10 unprotected people exposed to the virus are infected and do contract illness. Additionally, for the most part, in public health, and as Lori kind of outlined, is that we're always working backwards with measles. People spread it before they know they're sick. Someone with measles is contagious 4 days before rash onset and then 4 days after. And the symptoms that are in the prodrome often present like respiratory viruses. By the time the rash presents and is diagnosed by a provider or picked up in public health surveillance, exposures have already happened and potential transmissions have already occurred. So you're already behind the 8 ball there by the time the case has been identified. Additionally, a measles response is very resource intensive, often requires late hours, extra staffing, rapid contact tracing, having vaccine on hand, being able to put some of those motions into place to get vaccine on hand if you don't have the stock currently, access to rapid laboratory testing and extensive communication to the public and healthcare continuum. Specifically in Arizona, I think it's occurring elsewhere throughout the nation. Some of the smaller, more rural jurisdictions and health systems may have limited funding and resources. So you have to get creative and think outside the box to implement some of the public health actions that we have in our toolbox. They may not be the traditional tools that we're used to utilizing. I think some of the biggest challenges that we've experienced in the US and in Arizona is not just for the current measles outbreak, but for public health overall is the erosion of trust in public health post-pandemic and the vaccine hesitancy and misinformation, which is kind of why we're here to speak about it. So just to illustrate this, a key component in a measles response is contact tracing and identifying exposure sites. However, if people refuse to answer calls or provide limited information upon case interview, it's hard to implement preventative measures and tools of our public health toolbox. Additionally, you can provide education on vaccine. Sometimes it falls on deaf ears, so you have to get a little bit creative, especially in the new landscape and with social media and all that. But if you host a vaccine campaign, you provide clinics, it really just depends on the uptake. And if uptake is limited, the most effective tool for measles prevention is then reduced. Yeah, I think that's all I have to say on that.
Thanks for giving those insights. Maybe a few questions back to you, Liam, about the outbreaks that you've been seeing. I had heard in another state that there was concerns from a clinician that people weren't coming forward with measles, that they had observed people in the town that looked quite visibly like they were infected, but that they weren't, under observation or isolation. I'm just curious if you think that that's been a challenge in your state. And the reason why I'm asking that is obviously that's often a challenge in outbreaks, enumerating all the cases. But when you're trying to interrupt transmission chains or even construct transmission chains to know who gave it to who and where it's going and where it may be headed next, I can imagine that would complicate that. Has that been something that's come up in your state?
I think it's something that's come up in public health overall. That's not just measles related. Just the kind of hesitancy to potentially work with public health agencies or governmental agencies. So there's definitely a eroding trust there of public health that has potentially caused some hesitancy and not, I guess, not working with, but kind of elaborating on all their exposure history and movement during that time. As with, this isn't just for measles, but for everything. Public health surveillance works by healthcare seeking behavior for the most part. So people have to go seek healthcare to be able to be picked up in public health surveillance, reported by a provider. Often they have to have a lab test run to be able to be reported via passive public health surveillance. So, and that's for flu, COVID, beyond measles. So what we're actually getting in public health surveillance is really just the tip of the iceberg. And then there's the whole underneath of the ocean of the iceberg that is actually kind of occurring, but we may not always have insight into it.
And then can I ask you about the vaccination clinics, what the experience has been there? Has it been, we hear sort of mixed reporting initially in Texas, where the outbreaks seemed to start in early 2025. There were reports that some pharmacies were unable to keep MMR stocks because there was such a demand. But then we subsequently heard about challenges of uptake in some of the affected communities. And I'm just curious what the general response has been in terms of offering vaccines, and are people seeing measles and thinking, oh, this is bad, it's something that I want to protect my kids against, or is there still pushback against the vaccine in affected communities?
I think there's two fractions of the population. There's the fraction that's going to be vaccine hesitant, and you may not be able to change your mind no matter what education or communication that you provide. And then there's the other piece of the population, kind of like what you highlighted, that and kind of what we reviewed before, is that measles traditionally hasn't been seen. And then once individuals start seeing what measles looks like and how sick you can be from measles, uptake is then they seek out vaccine for preventative measures to protect their family. So that's what we've experienced so far with some of the vaccine clinics and campaigns.
It's maybe stunning for people who, didn't think twice about vaccinating their kids according to the schedule, but certainly thinking that there's a deadly outbreak that's raging, the deadliest outbreak in 25 years, it may be hard for people to understand that even in that context that there wouldn't be uptake. Maybe, Lori, if I could turn back to you to kind of, why would that be? Why would there, so like, what are the biggest misconceptions that, I'm sure you get asked a lot about the vaccine and about measles, and are engaged in that frontline work of communicating the risk benefit decisions, and what are the questions or obstacles coming up that are preventing people from wanting to protect their kids?
Sure. So, one thing that I've learned to appreciate much more is that if somebody had questions or concerns or hesitancy or low confidence, whatever we want to name this, and they found an answer that, satisfied their curiosity. So, the questions being, does MMR cause autism, or does MMR cause cancer, or will there actually be a treatment for my child like vitamin A that will just cure this virus if they get it? If they get a first answer to their question that's incorrect, but they got an answer, the work that we have to do to undo that answer takes a lot of time, just solely by the, human behavior that was the first thing they heard, and that sticks in their mind. So we have a lot of undoing to do. Now, some folks are very interested in having more of a conversation about that. Like, I saw this on Instagram. Is that true? Why would they say that? Or, I used to think this, then I heard this, and this one's from the federal government, so maybe I should, help me know. Those folks, we can help, right? Again, with time, we can talk through, where are you getting your information? That's a great question. I'm hearing that a lot. And you can kind of move them towards the reality of the science and help them make a good decision for their child. But for other folks who are just so fixed in their belief, like MMR causes autism and there's nothing under the sun that you can say that will change my mind, the more you talk about it with them, the less likely you're going to be successful. So, I've really tried to approach all of these families with the same kind of respect that I would want to get for my questions. Like, can I use Teflon? Or like, how many grams of protein am I really supposed to have? Like, I don't know the answers to these things, and I don't have the training to find out about those things. So someone help me. And I want that help. And, we really have to recognize for families, like, there's just so much out there that we have to take the time to help them. So it's time. I really spend a lot of time. I'll have patients come to my ID clinic and actually just spend an hour talking about their vaccine questions, which is fine. I can do that as a subspecialist, but a primary care doctor or someone at a pharmacy clinic or a public health clinic, like you don't have an hour. So I think that's the most challenging thing for folks that are unsure if they want to be vaccinated.
Yeah, I'm really struck by you said if we have time, and I remember when COVID vaccines were first approved for children, receiving from my kid's pediatrician's practice, which was a very large practice that covered most of the families in the state where I lived. As soon as that announcement came through, getting a message from the practice that said, "Don't call our office to ask about this vaccine because we just can't handle your calls." And it was understandable. It was during the pandemic and they had a lot of patient volume and they just couldn't engage. But then I thought, well, if we can't talk to our pediatrician about this vaccine, who were we supposed to talk to?
Yeah.
Pam, does this track with your experience in state in terms of the questions or the hesitations or the challenges of doing communication around the vaccines in an outbreak context? Are there resources for parents if they can't talk to their pediatricians?
So Arizona is also a decentralized state, so the local public health jurisdictions have oversight over most of that. So I'm probably not the best person to speak to some of those things. But I think just from an overall approach, with some of the vaccine communication, I think it speaks to what Lori said, is that sometimes people just you can blast out all this information during an outbreak and then you become desensitized to it and kind of tone deaf to it. So that's just something that we consider with our communications approach.
Yeah, yeah. I remember we had studied, was part of a study of the measles outbreaks that occurred before the pandemic in 2017 to 2019. And one of the things I remember from that study was how difficult it was for health departments to respond to the measles outbreaks, just given resource constraints. So you mentioned, Liam, the importance of contact tracing. That was a hard thing for many health departments to do at that point because they just didn't have the resources, the personnel, the time, the staff. And so the response often was to put out press releases to say there's been a measles case, it was in this place at this time. If you think you've been here and you think you've been exposed, talk to your healthcare provider. Which, is a reasonable message, except it's hard to square with what we just talked about, which is, do they have the time or the ability to actually have those conversations? Are they even equipped to have those conversations? And it seems to me that we need to figure out some place for people to go to get that information. I don't know if there's been any great work or development on that front. Laura, you've come off mute, so
Yeah,
maybe.
yeah, I can share. We actually built this out of the pandemic, and I mean, are truly, truly lucky that we got to keep it. Pre-pandemic, we had, and we still have something called the Poison Control Center at CHOP, Children's Hospital, and that was the place where, people could call and say, like, my dog ate crayons, or really, my child ate whatever, the Play-Doh, do I need to worry? And we leveraged that center and switched it into a public health communication center, where we staff it with the same individuals, but when we recognize there's a specific topic that the public might need extra questions answered, Tylenol and autism, we staff those individuals who are trained in one, general communication skills, how to talk to somebody when they're scared and it's their health at risk and don't have another place to go, but also with the clear information. And so, when we've had measles cases in Philadelphia and we anticipate calls, we provide that number. Anybody in the city can use it, and it's been a really great resource. And it's one of those things that we're very lucky to stand it up, and we partner with our health department on that. But not every place has that. And it's one of those little gems that if you can show this really helps, we need to fund more of these kinds of centers. I think that's a tiny nugget of help. But we know, if there's 180 kids exposed and one primary care office is kind of in the geographic region, they can't handle 180 calls. They're doing their regular work for the day. So it's really beneficial.
Strikes me that's a very similar, if you've had a infant, and depending on where you've delivered, sometimes, they have a warm line for, breastfeeding questions, for instance. And I know that was incredibly useful to me as a new mother. But it seems like a similar kind of approach. They're not really clinical questions in that moment, but, evidence-based questions, advice-based questions. Yeah, that is a really interesting idea. Maybe turning back to the outbreaks in the US. Liam, I'm wondering your thoughts on kind of where we are. First of all, it's not slowing down. I mean, for what we see looking at the data, it's not slowing down. I mean, more than 200 cases per week as of late, which is larger than what it was when it started. Seems like it's not slowing down. Are you still sort of activated and concerned about measles? And there's been a lot of conversation about whether we can link cases between different states and whether that should matter from an elimination standpoint. There's been an interest in potentially using genomic analysis to see if we can link cases, or perhaps in some instance hoping to delink cases. So to be able to say that this isn't a full year of ongoing transmission, that these are discrete outbreaks. I'm just curious, what do you think the evidence says right now for the cases that are occurring in the U.S. and are you looking to genomic analysis of the cases?
So just kind of overall, I think measles is really good at finding pockets and places in the nation where immunity has slipped with certain community characteristics that can unintentionally create those conditions and prime for outbreaks. As far as linkages, I can't really speak to that, but we do utilize genomic analysis. So in measles outbreaks, genomic analysis is a powerful tool for determining whether cases are linked due to genomic relatedness, identifying likely importations, and assessing whether transmission has been sustained over time. However, because measles virus evolves fairly slowly when compared to other viruses like influenza that evolves seasonally, which is going to be the seasonal vaccine, um, genomic data cannot reliably identify specific transmission events, exposure settings, or individual sources, nor can it explain some of the social and structural factors that allow outbreaks to occur. So kind of as a result, genomics is very much a new field with measles epidemiology. We typically refer to genotypes with measles, and we're starting to get more into the sequencing data as of recently. But it's most effective when used in complement with, rather than replace traditional epidemiology at the community level. So you need some of that epi level metadata that pairs with the genomic data that you're getting back, because each genomics by itself may not be able to tell you the whole picture.
And just to help people understand, is it currently possible to, with the tool, say, I think you said this, but I just want to make sure that it's clear for people who are listening, to be able to say cases in South Carolina are definitively linked to a transmission chain that started in Texas, for instance. I'm just saying that hypothetically.
Without the epi data, you can't make that conclusion with genomic data.
Yeah. Yeah. Okay. We have questions piling up in the Q&A, and I want to turn to them. So let me, and I encourage other folks to put some in. I'm just going to go through and sort of read them. The first one seems like an important statement rather than a question, but it says, I had measles as a child because there was no vaccine then. Besides the misery of itching, etc., I experienced vision damage. I was told that I was lucky not to have been blinded by measles. Lori, what's your take on that? Any reactions to that?
Yeah, no, I mean, I think we hear these types of comments from individuals of the generation where measles circulated, and not just about measles, but about, these other vaccine preventable diseases like I had Hib and I'm lucky to not be deaf, or I had polio and I'm lucky to be able to walk. And again, we have a whole generation that lived through the illnesses. And every once in a while, I will encounter a grandmother who says, how do I make my daughter vaccinate her kids? Like, these are my grandbabies and I know what they're up against. And so, these stories help. Stories in public health communication really do make a difference. And I think intergenerationally can help within a family. I mean, sometimes we look to our parents and say, we're doing it differently these days, but we got to keep trying and make sure that kind of the parent generation right now understands what their children could be up against.
Yeah. Okay. Go to the next one. How do we ask the public what they need from public health and government institutions to build trust? We do all we can to deliver information, but public trust is still low. Maybe we need to ask the public directly what it will take for them to trust scientists and doctors. Liam, Lori, anything to weigh in on this?
Yeah, I think that I've been thinking a lot about trust recently, and generally we think there's maybe three components, and some of it we have, and some of it we need to figure out how to give, which you'll hear this spoken about in different ways, but the three C's, like credibility and caringness and character, and so credibility, that a lot of people may have because they graduated from a school or they have an experience, and that kind of says, like, I have my white coat, I've got something, or I'm standing behind this pharmacy counter, I have something. But the caring and the character really takes longitudinal interactions with people. You can't earn that in a few minutes, and it's not given to you anymore. So I think that really looks at public health as doing the really grassroots work of being communities, finding trusted messengers, and making sure that the person that person saw when they needed extra formula during formula shortage then is the same like physical person, same face who the next year says, you trusted me when you needed formula. Now we're talking about vaccines, different topic, but you know me, I've been in your neighborhood all year. And that is, really fundamental, like public health work where we can't be behind a desk or putting out just like words on Instagram. It's that human connection where people see, I care about you and I know you. I know that you have 2 kids. I know that you had a baby last year. And that's when a crisis comes up, they're going to look to you and say, I'm going to trust you.
Hard to show up in people's lives for the first time in an emergency and ask them to do an extraordinary thing. Liam, maybe ask you in terms of what your state's approach has been to this problem, and I guess to say, do you feel like you have the resources to be able to do what you feel like needs to be done? I asked that because that was another lesson that I learned from that study that we did of measles outbreaks prior to the pandemic. It was very hard for a lot of health departments to do the kind of community engagement work to build the trust, to build and maintain the trusted relationships with communities that were affected by the outbreak. It takes resources, it takes time, it takes money, and they didn't have it. And so it was very hard to do. And so the places that did have those abilities had a little bit easier time. But Liam, what are your experiences?
I think we already touched on that a little bit, but the biggest part is building the trust with the folks in the community that are the trusted communicators. And that does take time. And unfortunately, with the pandemic, that eroded a lot of trust and a lot of time that was spent building up some of that trust. But yeah, we do utilize our trusted communicators to push out any messaging that we may need to push out. And I think the biggest thing nowadays is just making sure the messaging is clear, is understandable for the public, so we're not speaking using medical terminology and language around like that. So yeah, that's been our biggest approach, is just using those individuals in the community that people trust and seek out for advice, and being able to work with them, identify them, have them in this network, to be able to utilize them for different things, not just measles, but other public health issues that may arise in the community. I think that's been the most effective approach, but like I said, the trust has been eroded. It's spent a lot of time building up, and it takes so much time to build up and just a fraction of a second to lose it. So that's the hardest piece here.
Okay, and I'm going to the next question here. It says, what role for mandates, for instance, school entry, etc., or state requirements for some occupations involving handling of children's daycare? I assume this means vaccine mandates. And I guess the question is, what is the role here? I have some thoughts, but I'm curious, either Lori or Liam, if you have any insights on this.
Yeah, I can start. I think, the public's appetite at large for mandates is minimal to none. And, it probably is something that subverts the trust we just talked about, which is to say, if you say to somebody, you're going to get this because I said so, you've forgotten all those other steps of helping people understand and know why you're doing it. So, for schools, I mean, every state has school entry requirements. And the real limitation there is many states have the ability to send in philosophical or religious exemptions that can be very, very minimal, right? You can have a family write on a piece of paper, I don't want to vaccinate because I don't believe I should. That's a legitimate exemption in certain states, that doesn't need to be sincere. It doesn't need to say what their philosophical exemption is. So, that could be less relaxed just to keep our schools safe. But the bigger issue is if people are going to that extreme to try to get their child out of vaccinating, why are they? Is it that they're truly scared or nervous? Is it that they don't have access? Is it that it's easier to write that piece of paper than wait on hold at their pediatrician's office to schedule? What's driving that desire to not vaccinate? And until we sort of undo those, the mandates just kind of create more distrust and more anger at the problem. So it's a good solution in an absolute crisis. I mean, last time Philadelphia had compulsory vaccinations in 1991 when multiple children were dying and thousands were being hospitalized. Then yes, it's like the last lever public health has. But this moment, I think it's not the one that's likely to succeed.
Mandates come up in Arizona, Liam, or in other states. I'm sure the states talk about this issue of mandates. I remember for the big outbreaks in the 2017, there was or maybe even earlier, there was a push to try to reduce the number of legal mandates, reduce the number of legal exemptions to mandates. That was a big legislative push. We seem to have now gone in the opposite direction. So it seems like the field is somewhere different than we were, a number of years ago, but.
Yeah, I mean, we're one of those states that do have multiple ways to get exemptions for schools. But I would just say that generally compliance with some of the public health actions that are in our toolbox, exclusions, isolation guidance, and quarantine recommendations are not as generally accepted as they were in the past. So we're very much in a world in public health where it's just understanding what's feasible for the community you're working with and working within that feasibility. I mean, I'm in a place where you can utilize some of the tools and understand where they're coming from as well to effectively enact or implement some of the preventative measures for said diseases.
And as a general premise, I mean, public health, we teach, is supposed to operate by the least restrictive means necessary. And we have to distinguish between things like mandates that may routinize what is already highly accepted behavior, such that people don't forget to do something that they would otherwise do, but may just need a nudge to do it, versus a attempt to force people to do things that they don't feel like is in their best interest. That's a very, very hard thing to do. And so if we are at a state where the feelings aren't there, then I think the mandates themselves are not going to be able to overcome that. We have to do the ground game of helping people understand why vaccines are beneficial and to feel confident in the safety and efficacy that they provide. I'm going to scroll down here in the sake of time and see if I can kind of condense some questions. Here is one thought that says, growing up in Turkey in the late 80s and early 90s, there were two things done. It was very effective: mass vaccination at schools, heavy media and school campaigns that were designed to scare people. If you get measles or rubella, you'll die, and vaccines will protect you from death. Why don't we communicate our message more clearly in layman's terms? It's a choice between vaccine equals life and no vaccine equals death. I'm curious about your thoughts about that. I have my own thoughts on that, but Laura, you're having conversations with people a lot. Do you think this messaging will resonate now?
Not anymore, mainly because it needs to be, the data needs to be what their lived experiences. What we find is you can share data with individuals, and if they have an anecdote that differs from your 30 years of data, their anecdote has a lot more power than all of the data. And what we also find is, again, this is just human behavior and how our brain works and what we do to protect ourselves. If we say 3 out of 1,000 children are going to die of measles, what a family hears is 997 aren't. And I'm pretty sure mine will be in that 997 because nothing bad has happened to my kid yet, right? And so and nothing's happened to my neighbors. And there was that big outbreak in Texas, and it was only 2 kids. And, when I hear only 2 kids, I think, oh my God, 2 kids died who didn't need to die. And that was tragic and horrible. And I wish that never happened. But the public hears, certain people in the public hear only two. And look at all of the children who did okay. So, we just need to make sure our messaging matches what they're seeing and hearing. And, the fear has to be real. If their neighbor's child died, yes, they will be very, very scared. But otherwise, it's just not going to resonate with them.
Yeah. Yeah. Liam, have you encountered or derived or stumbled upon or developed, have you seen any kind of evidence-based approaches that work, either in your own state or in other states? I know folks get together and swap stories and share insights. Anything that you think is kind of emerging as a best practice around communication or promotion of vaccine related information, kind of overcoming some of the misperceptions, et cetera?
I think the biggest success is just being clear and concise about some of the messaging as well, and then having the messaging come from those individuals that are trusted. I do go back to you do have to be careful in the landscape today with what we call fear mongering. So because then that goes back to the conversation about credibility.
Yeah.
And if we do that too many times, then we do lose credibility if they don't have the shared experiences that Lori is talking about. So you lose the effectiveness of your voice. So.
And in terms of this like trusted messenger, I mean, I imagine it's different for every community, every different situation. Are there approaches to identifying who that is? Is it done sort of on an ad hoc basis in the midst of an emergency, or are there approaches to kind of curate and cultivate messengers, trusted leaders beforehand? I'm just wondering if there are any best practices here we can look to.
I think a bit of both.
Yeah.
It's definitely identifying them as they come as beforehand as part of the preparedness side of things, but then also you're not able to predict where some of these outbreaks may occur and what communities they may occur in. So you might not have those trusted messengers in your deck to utilize. So we've been fortunate enough to have individuals in certain communities that have been able to be in public health as well, that are able to be that trusted messenger. So we've been fortunate there, but yeah, I think it's a bit of both.
Mm-hmm. Scrolling down here, there's one comment that I want to be sure to highlight. It says, for what it's worth, federal scientists are still following the science, regardless of public-facing information we can't control. What can we do to help state public health labs to share data with the public quickly? Are there specific bioinformatics tools or expertise that could be helpful for states to make routine data sharing optimized? Just want to say thank you for that comment, particularly in light of my opening statement where I talked about some of the muddied communication. Clearly, that does not apply to all in the federal government who are working on these issues. And I'm very grateful to those who are working on these issues. So thank you for that. Liam, what any insights on this data sharing issue, or anything? And maybe I'll expand that to what do you think states need right now to help in responding to this? What's one thing that would make your lives easier, better?
Funding. I think the biggest thing that we've experienced is just sharing. We have Four Corners calls, Western States calls. This is shared experiences and just having individuals that are in the same field work through some of the experiences that they've encountered, roadblocks they've encountered, and how they've resolved said roadblocks has definitely been a huge help when you do encounter those situations in your own jurisdiction. So I think overall, just the communication, utilizing some of those national groups like CSD for lab specific APHL, utilizing your colleagues in those networks, and then just bouncing ideas and things off of those groups has been I found it to be very beneficial.
And does that happen regularly that states are getting together and sort of sharing experiences or sharing data to try to help optimize their own individual responses? Is there anything that could be done to help support that?
We have our set calls, but a
Mhm.
lot of these are we started having like ad hoc calls. So at this time, I don't know how to say, or I guess address the how can support be uh, what support may be needed, but yeah.
Okay, great. Um, just trying to look here and see. There was a comment on, I think to the earlier question about genomic analysis. It says, I've had issues building reliable trees for phylogenetics due to variability in the non-coding region between the M and the F region. Agreed, it's difficult to use trees to determine relatedness. Okay, thanks for sharing. That's anonymous, but thanks for sharing those insights. Let's see. Anything else that we haven't really covered? There's some comments about kind of earlier vaccination campaign successes, and I think we've already sort of talked about how we might be in sort of different circumstances now, both in terms of the prevalence of the diseases that these vaccines try to combat, but also the information environment and the level of trust in the institutions making recommendations. So I would suggest that there. Let's just see anything. Maybe I'll ask you both a question. What do you think the biggest misperception is about either your work on this topic or the topic itself? That, like, if you could get someone's ear right now, that you would try to correct. And that might be a hard question because I'm sure there are a lot of them, but if even just whatever comes to your mind, use it as an opportunity. We've got, lots of people listening in. What do you want folks to know that they may not know about measles? I'll start just while you're thinking. Give you a second to think. Which is, I've been getting a lot of questions lately about measles elimination and sort of like, well, what does it really mean? And, one of the things I say to people is, listen, it's not like a bond rating. We're not gonna, it's not gonna change our interest rates. It is an aspirational goal that we set out decades ago because we thought it was in our best interest, both from a cost and health perspective. And losing that status is an embarrassment. It's also an indication of the ongoing threat to our health. And it's also an indication of broader vulnerabilities in the system that make us weak and unready to respond to a range of other disease threats, including worse scenarios than we've experienced during COVID. So that's one thing I just want to say, which is, like, to your point, Lori, about like this a bit of a canary, measles vaccination coverage and the ability to contain measles outbreaks is a good indicator of how strong the public health systems are. And when we struggle with that, then that gives us concerns that we may struggle further. But in our 2 minutes left, anything else that may have
Yeah,
sparked?
the thing that I've been talking about the most is helping folks who are doing the hard work realize that there are some bad actors out there, right, who are spreading misinformation and really making our jobs very hard. The vast majority of the public, are victims of this. Like, this is not their fault that they have questions or are refusing or are confused. And we really have to kind of embrace them and recognize we need to just keep helping, not kind of pushing against like the anti-vax and us, because it's not. I mean, it's people with really hard, curious questions because of the information atmosphere, and we can sort of help them and deliver for that crowd. So that's the biggest thing, is just to kind of break down that us versus them and just say there's a lot of people who need a lot of help, and I mean that's what we're all set out to do. So it's even harder than it ever was, but I think that's kind of what we signed up for.
Great. Liam, anything to add in a few seconds of time remaining?
I think you both covered it pretty well, but just that public health is here to be a resource and to we're here to help with wellness and individual health. And yeah. public health is here to be a resource, and we're here to help.
Well, thank you. Thank you both for joining us today, but also thank you for your ongoing work to help tackle these issues. Really appreciate it. It's very hard. It's very important, but I'm grateful to you both. So thank you really for joining us today for this conversation. I'd also like to thank, and as we close out here, our team at the Pandemic Center who helped put this event together: Bentley Holt, Michael Mitchell, Leah Levgren, Amanda Kogan, Carly Gasca, Aaron Johnson, Andrea Ulig, and Alice Im. To stay up to date on future sessions, you can use a QR code, which I think is now on the screen, to access our link tree. There you can sign up for our webinar mailing list, catch up on past recordings, and explore other resources like our weekly tracking report, which includes updates on topics like measles, flu, mpox, and emerging global outbreaks. A recording of today's session will be available on the events page of our website next week, along with our other previous webinars. And if you enjoyed today's webinar, you can sign up using the QR code on the screen for email alerts for future discussions. And please follow us on social media for updates on this and other things. And feel free to reach out with questions or suggestions. We'd love to hear from you, including what other topics we should cover for this webinar series. And with that, thank you for your attention, for tuning in, and we are adjourned. And I wish you all, I hope you all stay safe, stay healthy, and stay engaged. Thanks so much.